Uh, am I audible?
Yes, sir.
Thank you. Good evening, everyone. Thanks for the opportunity by RSTA. Today, I'm going to start with the oral paper on case report of fat pancreas in a lean person, a case of pancreatic lipomatosis. So here comes the case report. A 49 years old male who is a known case of type 2 diabetes mellitus for the past 15 years comes with complaints of loose stools um, for 6 months. Loose stools for 6 months, which was on and off for the first 4 months, more after taking meal diet, and last 2 months, which was daily and after each meal per drink, and 4 to 5 episodes per day. The stools on examination is yellowish in color. I mean, we are eliciting history covered with greasy, slimy layer, which is large in amount and not blood stained. No bad odor and no worms in stools. Other relevant histories history of loss of weight about more than 15 kilogram in last 6 months, and history of loss of appetite, history of ulcer over both foot, and history of less ambulant for the past 2 months. Regarding the past history, he was a diabetic for 15 long years. Earlier, he was on oral antidiabetic. Later, switched to insulin for 2.5 years. And during admission, he was on human premixed insulin. 12010, no other comorbidities, no past history of any surgeries. And personal history, he takes mixed diet. And the important thing to rule out, to consider here is not an alcoholic and smoker and other substance abuse. And examination, conch is oriented and is thin built and malnourished. Pallor is present, leukocytia present, and bilateral pitting pedal edema, and the vitals were stable. And the patient weight before 1 year is 63 kilogram. Now the current weight while on admission was 45 kilogram. The BMI found to be only 14.07. So on system examination, CVS, RS and per abdomen were normal. On CNS examination, there is a bilateral symmetrical sensory motor polyneuropathy present with the pressure source over the both foot and above heel. And first, we have made a diagnosis provisionally diabetic with the diabetic peripheral neuropathy with the chronic diarrhea for evaluation. On routine investigation, total count on CBC hemoglobin is 9.3 and RFT is normal, and urine routine doesn't show any albuminuria. And LFT is normal with the elevation of ALP alone, and hypoproteinemia with hypoalbuminemia. TFT is normal, and serum electrolytes found to have hypokalemia due to chronic diarrhea. And USG abdomen, distended gallbladder and bladder, and minimal free fluid in the abdomen and pelvis. Otherwise, other organs appears to be normal, and pancreas couldn't be visualized. Fasting lipid profile is normal, and serum amyl is not elevated. During the admission, his blood sugar level is fluctuated. So second day morning, he developed hypoglycemic symptoms and seizures, and we can see that graph here where there is a fluctuation of the blood sugar fasting as well as postprandial blood sugar level from the baseline. And so because of this labile blood sugar level, couldn't measure the C-peptide, and for the evaluation of the chronic diarrhea, so according to history, I clearly have a stigma of malnourishment and the weight loss, like fatty stools of large volume covered with greasy, slimy layer, and each of may more after taking food, and all these things. And stool examination, greenish yellow color, semi-solid, and blood and mucus were blood absent, mucus were present, and microscopic shows no RBCs, ovocyst nil, and culture were negative, and VCTC viral marker were negative. So we on further evaluation, drug-induced diarrhea, fecal incontinence, and due to diabetic autonomic neuropathy, all are evaluated and ruled out. And we come to a provisional diagnosis of malabsorption diarrhea with the history and examination and the investigation. So malabsorption diarrhea. So among the quantitative and qualitative tests to confirm the steatorrhea, so we have done a qualitative test of Sudan blood stain of steatorrhea, which comes as positive. So we confirmed it as a steatorrhea and proceeded. So on further workup to rule out the etiology of the steatorrhea, we have done CCT abdomen and planned for ogiroscopy and duodenal biopsy and the fecal elastase test and pancreatic function test for pancreatic insufficiency, as we are suspecting in this case. And so first we took CCT abdomen, and one remarkable thing came out in which the pancreas is entirely replaced with the, I mean, around the fatty replacement and around our Hounsfield unit of 80. So no calculi, no other parenchymal visualization is there. Entirely is a clearly they depict it as a dark pancreas. So we can see here is a dark pancreas. The pancreatic parenchyma is replaced with fat. So this is the normal pancreas for the comparison, CCD abdomen, and this one is the dark pancreas, which came out in contrast enhanced CT abdomen. So on CT report, they have given it as a appears bulky and parenchyma replaced by fat and minimal free fluid in the abdomen, and which impression given as a pancreatic lipomatosis. So this is the thing we have got in the journal where the few cases are published in total pancreatic lipomatosis. In here, it is in our patient that total pancreatic lipomatosis is a dark pancreas. And we have made a final diagnosis of diabetes mellitus, malabsorption diarrhea, which is due to pancreatic exocrine insufficiency, which in turn is due to total pancreatic lipomatosis. So we have given the treatment of meal plan diet with low fat diet and pancreatic enzyme replacement around 25 to 40,000 lipase units, and vitamin and iron supplementation, IV albumin, and supportive care. So regarding the total pancreatic lipomatosis, it is a rare entity, but it is usually insidious, so that it will be mostly asymptomatic with varying clinical signs and symptoms. So we couldn't easily identify that, and it should be considered in the differential diagnosis of patient with malabsorption and patient with the diabetes and malabsorption. So CT or MRI with MRCP may be the effective imaging methods used to establish the diagnosis. So usually the causes will be obesity associated with metabolic syndrome, or congenitally associated with cystic fibrosis, or Schwarzman-Diamond syndrome, or it may be associated with chronic pancreatitis also. So the thing about diabetes is the total pancreatic lipomatosis may lead to diabetes because of the exocrine as well as endocrine deficiency. Sometimes the chronic diabetes patients may end up with total pancreatic lipomatosis. So the other way around. So the both are the possible thing. So it can be treated with dietary modification and pancreatic enzyme replacement along with diabetic control. So it is a rare case, which few cases were present in Indian journals also. So this is my case report, and thank you very much for RSSTA for giving me this opportunity to present this case in the world renowned forum. And thanks my HOD, Dr. Natarajan sir, Dr. Sandamari sir, and Dr. Sangamani sir from Madurai Medical College. Thanks a lot. Hello, sir.
Yes, sir.
So, is there any question answer session, or the session will be move on, sir?
Sir, question answer session is in the last, sir.
Okay, sir. Okay. I'll wait, sir. I'll wait for the next presentation. Thank you,
Okay,
sir.
sir. Thank you. Thank you.
Thank you.
Good evening. Shall I start my presentation?
Yes, sir. Yes, sir. You can start.
Okay, thank you. Yeah. Are you able to my scene screen? Shall I start? Yes. Yeah, good evening. Myself, Dr. Naresh Sen. I would like to thanks to the organizing committee and secretary and the abstract jury to giving me the good opportunity to present here. My topic is importance of the LV, left ventricular global longitudinal strain in COVID-19 patient with type 2 diabetes and heart failure. I'm a Polo Hospital group. See, the background is the novel coronavirus disease, COVID-19 or SARS-CoV-2 virus. It is responsible to the myocardial ischemia or myocarditis which precipitate the heart failure. Pro-BNP, the brain natriuretic peptide, is a marker for the cardiovascular heart failure, but is limitation for the normal ejection fraction. Several studies show the importance of LVGLS is reliable a prognostic factor for the heart failure. So objective of the study to assess the left ventricular global strain in diabetes, cardiomyopathy, heart failure, preserved ejection fraction or low ejection fraction to assess further the cardiovascular morbidity and mortality associated with different global longitudinal strain of the LV. Method of the study we performed observational studies between the 2020-21. We enrolled 74 cases of diabetic cardiomyopathy patient with the heart failure as compared to the other COVID-19 patient without diabetes. Include the adult 49 mean of the age, the NYHA class 1 to 4, and male versus female ratio is 3 or 2. Especially the LV, global longitudinal strain was assessed the velocity vector, the 2T echocardiogram, 2 chambers, 3 chambers, and 4 chambers with the Simpson method priorly to check the LV ejection fraction, divided 2 groups, heart failure, reduced ejection fraction less than 50%, or heart failure, preserved ejection fraction is more than 50%. We check the ejection fraction with the L-diastolic volume and systolic volume formula by the Simpson method as per the 2D echocardiogram, 2 chamber, 3 chamber, 4 chamber. The advanced technology is strain imaging. Look the picture of the strain imaging, the straining of the LV myocardium with the bull-eye phenomena to check the graph, the shortening and lengthening of the LV myocardium and check the systolic function of the LV. BLS is very important to the special tracking, but it has limitations, some age vary and machine vary and sexual verification, but the studies show that less than 60% of the GLS is significant to detect the heart failure by the LV. The inclusion criteria and exclusion criteria over there is more than 80 years of the age, left ventricular ejection fraction more than 25%, HbA1c more than 7, or RT-PCR positive for SARS-CoV-2 virus positive. Is exclusion criteria. We exclude in studies hypertension, coronary artery disease, CKD, hypothyroidism, congenital heart disease, pregnancy, valvular heart disease, systemic inflammatory disease, previous history of viral myocarditis like influenza and HIV and pneumonitis. Results saw the found significant result the LV globular longitudinal strain, the LVGLS in diabetic cardiomyopathy group minus 10.6 mean as compared to the minus 18.7, the control group. LV ejection fraction was assessed of 46 mean and the 59 as compared to the control group. But in the final result found that less than 10% of the LVGLS has significant 30 days mortality as compared to the heart failure patient. It shows that this almost 74 versus the control 70 cases. And central, we can see the mean ejection fraction 46 versus 59. And as LVGLS is low down with the red, minus 10 versus minus 18.7 with compared to the NPRO BNP levels. Another table we can show, we can divide heart failure reduced ejection fraction versus the heart failure preserved ejection fraction patient in diabetic patient with heart failure or COVID-19 patient case. 20 cases with reduced ejection fraction and 54 cases with preserved ejection fraction. Look at the ejection fraction is around 40 mean, 40% ejection fraction in reduced ejection fraction of heart and 56% in preserved ejection fraction. And coming to the down of the LVGLS is around 10 plus minus 2.7 standard deviations as compared to the 12 and minus 3.6% deviations. Mortality comparison with reduced ejection fraction and preserved ejection fraction. The chart is showing minus 10% GLS in reduced ejection fraction and minus 12.5% is preserved ejection fraction as control to 17%. This very important data show the 30 days mortality comparison between a diabetic patient, COVID-19 positive, reduced ejection fraction group versus preserved ejection fraction groups, 11% mortality in preserved ejection fraction, also as compared to the 15% mortality, 30 days mortality in reduced ejection fraction level. 30 days mortality is compared to based on another group. We divided those patients having ejection fraction less than 50% or LVGLS less than 10 or LVGLS is between 11 to 15. Is higher, mortality is 14% is less than 10, LVGLS is very significant marker. Limitation are studies, the two centers, number of samples is less, hospitalization is limited, variation about the statistical models, and the limitation apart from the echocardiogram machine in vary of the models and system of the electronic part. Is another part is some AC inhibitors and ARBs, heterogeneous part of the study is a very important limitation of our study to detect the LVGLS comparisons. Discussion the SARS-CoV-2 virus infection affect the myocardium, endocardium, the heart initially, leads to the myocarditis and myocardial injury and ischemia precipitate the heart failure. In diabetic patient, especially in immunocompromised patient, diabetic cardiomyopathy describe the diabetic association with the heart failure without confounding factor like CAD and hypertension developing the left ventricular hypertrophy and diastolic dysfunction initially, but we can pick the LV systolic function with preserved ejection fraction in the base of LVGLS. GLS is very important and several studies have gone for LVGLS, global longitudinal strain pattern in preserved ejection heart failure in diabetic patient. Also, we can pick the, and the data shows and the guidelines shows that less than 16% of GLS is very significant to detect the heart failure and pick the heart failure early detection, and less than 10% GLS is high mortality, 30 days mortality with heart failure patient in the hospitalized diabetic cardiomyopathy, not only in reduced ejection fraction, but also we found the preserved ejection fraction is very important. We conclude the study, the left ventricular global longitudinal strain has more significant value to assess heart failure. LVGLS is helpful to assess cardiac systolic function. Is diabetic patient where mostly physicians found only diastolic dysfunction with preserved LV ejection fraction more than 50%. Reference they are there. We would like to give the take-home message: early detection, prompt treatment, and reduced mortality in case of diabetes, heart failure, even preserved ejection heart failure, not gone for the diastolic dysfunction. Apart from that, we can pick the GLS, pick the LV systolic function in case of diabetic heart failure patient with normal ejection fraction. Thank you so much. Any questions? Respected sirs, any question?
RX events?
Dr. Aniket, you can start now.
Yeah, thank you. Shall I share my screen?
Yes, sir.
Just a minute. Hello?
Yes, sir.
I'm not able to share my screen.
Give me 1 minute. Hello, sir. We can show your screen.
Hello?
I can see your screen, sir.
But I'm not able to see my slides.
Sir, you can open PPT.
Just a minute.
Any problem, sir?
Yeah, actually not able to get that PPT on that share screen option. Actually, PPT is open in the background.
Okay, sir.
Sir, hello. Hello.
Hello? Yes, ma'am.
Yes, sir. First of all, please open your PowerPoint.
Yeah, PowerPoint is open in the background, ma'am. It's there.
Okay, come back to Zoom screen, sir. Zoom screen पे आ जाओ सर अभी आप.
Yeah, I'm there on the Zoom screen, ma'am.
Okay, आपको नीचे सर green icon share button.
Yeah, no. Now it's there, ma'am. Now
Okay.
it was not appearing before, but now it's there. I'm sharing my screen. Can you see my
It's coming,
slides?
coming, sir. It's coming.
Yeah.
Yes, perfect,
Thank
sir.
you. Thank
Just
you.
put it slide for mode.
Yeah. I thank RSSDI for giving me this opportunity to present my case in the annual event of Research Society of Study of Diabetes in India. I am Dr. Aniket Inamdar from Samarpan Clinic, Umarga. Along with my co-authors, I am presenting my study on association of fasting heart rate with fasting and postprandial blood glucose levels in Indians. I have no conflict of interest and directly starting with my background and aim. Diabetes mellitus is associated with an abnormal autonomic function. In diabetes mellitus, being it is as a metabolic disease, it usually has increased sympathetic and decreased parasympathetic activation. As we all know, diabetes and impaired fasting glucose are associated with the increased mortality, particularly with the cardiovascular causes. Several factors, including fast heart rate, have been identified to be associated with increased likelihood of having diabetes. Heart rate, as such, is a crude index of autonomic nervous system tone, reflecting the balance between the sympathetic and parasympathetic inputs. Especially in diabetics, there is increased sympathetic input, whereas there is decreased parasympathetic input. And it very well correlates with the muscle sympathetic nerve activity as well as serum noradrenaline levels. With the aim of this, our study was to establish the correlation between the fasting heart rate and fasting and postprandial blood glucose levels. For this study, 509 patients between the age group of 25 to 75 years were studied at different centers in India. The resting heart rate was recorded on finger pulse oximeter before taking the fasting blood sample. The morning blood samples were obtained by venipuncture after overnight fast of at least 8 hours, and the postprandial sugars were obtained after 2 hours after the breakfast, and the blood glucose estimation was done by the hexokinase method. The diabetes mellitus was defined in accordance with the American Diabetes Association as the fasting plasma glucose more than 126 milligram per deciliter or more, or 2-hour postprandial blood glucose levels 200 or more. The Pearson's correlation test was used for the statistical analysis. So what did we find? We found that the resting heart rate was significantly higher in patients with a higher fasting blood glucose levels compared with the patients with a normal blood glucose levels. And the difference was statistically significant with a p-value of 0.002. And not only that, it was also noted that the fasting heart rate was also significantly higher in patients with a higher postprandial blood glucose levels. Again, a significant p-value of a 0.002. In this, we can clearly see the correlation between the fasting blood glucose values along with the fasting heart rates. As we see clearly, as the fasting glucose level increases, there is increase in the heart rate. And that too happens in both cases, the fasting as well as postprandial levels. So as fasting blood glucose increases, the fasting heart rate increases. As the postprandial blood glucose increases, the fasting heart rate also increases. So coming to the conclusion, our study supports the hypothesis of a fasting resting heart rate as an independent risk factor for diabetes mellitus and as well as for impaired fasting glucose, because our study has clearly shown that there is increased fasting resting heart rate in case of both increased fasting blood glucose levels and increased postprandial glucose levels. And not only this, the patients who are non-diabetics also, even the fasting is in impaired fasting range. In those patients also, we have clearly seen increased fasting heart rate. The recent study by the Framingham Heart Study has clearly demonstrated the reduction in heart rate variability along with the sympathetic and parasympathetic imbalance, not only in patients with diabetes, but also in individuals with the impaired fasting glucose. The meta-analysis of 7 published studies confirmed the positive association between the resting heart rate and the diabetic risks. A resting heart rate is generally considered as a surrogate marker for autonomic activity, and increased sympathetic nervous system activity is usually associated with acute and chronic resistance, insulin resistance. And when there is acute and chronic insulin resistance with the background of sympathetic nerve activity, it again increases the heart rate, which could be an indicator of a surrogate marker of abnormal autonomic function. And one of the most important mechanisms that has been postulated for the sympathetic activation, because sympathetic activation, when there is a sympathetic activation, it leads to the vasoconstriction. And when there is a vasoconstriction, it decreases the blood flow to the muscle. And when there is a decreased blood flow to the muscle, there will be impairment of the glucose uptake by the skeletal muscles, leading to, again, increased blood glucose levels. So the sympathetic activation has also been associated with the diabetes-related risk factors, such as reduced insulin sensitivity, high blood pressure, obesity, and with a background of subclinical inflammation and metabolic syndrome. Ultimately, the exact mechanism by which the increased heart rate is induced remains to be elucidated. But however, our findings suggest that this area of investigation may be relevant for future studies. One of the remarkable result, which has clearly shown by the Framingham Heart Study, that whenever there is small increase in blood glucose levels, there is a corresponding increase in sympathetic activity and decrease in parasympathetic activity. And not only this, the Framingham Heart Study has clearly shown that increased blood levels decreases the vagal tone and ultimately again increases the heart rate. So this area of investigations needs further studies, and this is very interesting area to study the autonomic dysfunction in the area of diabetes and impaired fasting blood glucose levels. These are my references, and I thank all my co-authors and the RSSDI for giving me the opportunity to present my paper in the national conference. Thank you. Sir, any questions?
Shall I start my video? Okay, are you my video is visible? Okay, I'm start now. Thank you, myself, Dr. Naresh. I would like to give the thanks to the organizing committee, secretary, and abstract jury for giving me a good opportunity to present here. My topic is current approach of integrated management with allopathy and lifestyle intervention in Indian diabetes group. Diabetes is a major risk factor for the cardiovascular disease and obesity, and an additional risk factor for the same. The diabetes is defined as significant hyperglycemia with high limit of body mass index called obesity. And along with the obesity, diabetes could more risk of the diabetes, heart failure, heart disease, and stroke. Lifestyle intervention is primary health care consisting of the health, exercise, and education for the yoga, meditation, and diet counsel. Stress management, primary and secondary prevention for integrated approach of allopathy with alternative tools. Objective studies performed for the good glycemic control and prevention of cardiovascular complications in diabetes type 2 with obesity to assess the importance of integration of allopathy with lifestyle intervention. To compare cardiovascular morbidity and mortality between integrated approach of allopathy with lifestyle modification and allopathy alone. Methodological of the study, the observational study, the cohort study was performed duration of the 2-year follow-up integrated program with focus on pharmacotherapy with lifestyle intervention in patients with diabetes. Total number of patients 2014, middle age of the men and women, the ratio was the man and female is a 3.2. Diabetes type 2 and obesity were enrolled. Usually care in the group A divided 1,080 patients and another group divided as an integrated approach, allopathy with lifestyle intervention with 960 patients. Group B, designed a group B, the allopathy medicines, behavior counseling, education with balanced healthy diet, exercise. Pardon? Hello. Are you? My slide is. My slide is visible. Hello. Is the integration of the allopathy with lifestyle intervention. Group B, allopathy medicines, behavior counseling education, balanced healthy diet, exercise, superimpose the endurance, the yoga and meditation and exercise training with aerobics. 3 times a week for 3 months with integrated program for 2 years follow-up program. Inclusion criteria is 18 to 75 years of age, diabetic patient. Of course, the HbA1c level is more than 7, body mass index is more than 25. Exclude the criteria, we exclude the hypertension, coronary artery disease, CKD, congenital heart disease, pregnancy, valvular heart disease, systemic inflammatory disease, and previous history of viral myocarditis. Results. Proposed lifestyle improved after 2 years program. The group and group B difference, the 95% confidence plus BMI is significantly lower than group A, and bed circumference, best threshold, decrease in the heart rate, systolic pressure and diastolic pressure, HbA1c control, and significant value is p value is 0.002. The slide is showing the diagram is a body mass index improvement of 5.3 reduction as compared to the 1.5 in integrated group, and fasting blood glucose are approximately 35 versus 20 reduction, and ppVS are 56 milligram per dl in integrated group as versus compressed to the 30 milligram per dl down to the baseline, and HbA1c control is a 2.7 down as compared to the 1.9 of the baseline HbA1c in integrated group. After 2 years follow-up, the ECG and TMT changes and 2D echocardiogram is left ventricular hypertrophy, LV diastolic dysfunctions shows the chart. See the ECG ST changes now 11% versus the 16.6% in the usual groups, means the pink line as versus to the blue line, and pink group is a integrated group with the allopathy and lifestyle modification as compared to the 11.4 versus 16. ECG changes and TMT positive as 7.1% between the 15.9%, and LVH left ventricular hypertrophy in echocardiogram is 12% versus 21%, and diastolic dysfunction is 18% versus 32% in the usual group. See the importance of the 1.5 to 2 time fold improvement of the diastolic dysfunction and TMT positive and left ventricular hypertrophy, the help of the integration part. Another is unstable angina. We found 3.4% versus 12.9% as usual group, and in integrated group myocardial infarction, congestive heart failure and a stroke. The significant, you can see the pink bar is around 5.9% angina cases versus 13.9 cases in the usual group, and MI, myocardial infarction, is a 2.2% versus 8.6 in the usual group, and 2.4% congestive heart failure as compared to the 6.2%. And stroke, another stroke is 2.8% the integrated part of the group with allopathy, and alone allopathy is a 5.4% incidence of a stroke. Is a very, very important data is showing again part of the variable comparison, the percentage wise, the atrial fibrillation, ventricular tachycardia, and cardiac death. Atrial fibrillation in the integrated part is a red part, and the blue part, group A, is a only allopathy. See, the integrated part with the allopathy is a 2.9% atrial fibrillation we found as compared to the 7.2%, and ventricular tachycardia is a 1.2% as versus the 3.4%, and finally death found the 1.8% versus 3.6% in usual group. Limitation of our study, the 2 centers, sample data is insufficient, statistical model is the variable, the limitation of the lifestyle modifications such as the yoga, meditation, and diet vary towards the trainer and performers. The very They're very important. And another part is the improper or a heterogeneous implementation as compared to the standard guidelines. These are the limitation of the studies. The conclusion includes the studies, the regular 2-year follow-up, improvements in cardiac autonomic function, quality of life, decrease stress, improve personality and exercise score in integrated part with allopathy, better reduction of the heart rate, blood pressure, weight, BMI, weight circumference, waist hip ratio, decrease cholesterol level and sugar and HbA1c level. Also, decrease incidence of cardiovascular events in the integrated group, 2 to 3 times decrease incidence of cardiovascular disease, 33% reduction of cardiac arrhythmias and 50% reduction of the cardiovascular mortality and 35% reduction congestive heart failure in integrated group as compared to the usually group. None of the have conflict of interest our side. The take-home message we would like to the tight control of the glycemia, tight glycemic control and control of other co-risk factor of cardiovascular disease like obesity, dyslipidemia, hypertension could decrease cardiovascular morbidity and mortality. Allopathy is the best modern medical science to control the diabetes, but it has some limitations and adverse effect of longer duration therapy. Lifestyle modification is a supportive weapon to prevent diabetes and reduce the cardiovascular complication along with allopathy medication. Lifestyle modification is an integrator that should be keep in the mind of all physicians who are treating diabetes. Thank you so much. Thank you for giving me the opportunity and my co-authors and RSSDI chapters and abstract juries and procedure. Thank you so much.
Good day, friends. It's a very pleasant experience being with you, but it's even more special talking about something that is often ignored in our country. Let's talk today about an expert consensus that has been built up around the role and importance of high fiber in diabetes management, not only in India, but across the world. These are our conflicts of interest. Now, there is a growing trend in prediabetes, diabetes, and obesity across the nation. And this trend is accompanied by, or is perhaps due to, unhealthy dietary practices. One of the things that we tend to ignore in dietary management, in MNT, in medical nutrition management, is the importance of dietary fiber. There is a lot of scattered information available. People do pay lip service to the importance of dietary fiber, but we need to have a user-friendly guidance, and we need to have all this evidence and information in one person-friendly, reader-friendly format. So that's why 14 experts from India got together to discuss this concept, to analyze current recommendations and data, to prepare a draft document, and then to improve and edit it. Multiple rounds of discussion took place before the final draft was created. Now, what is fiber? Fiber is not homogeneous. There are different types of fiber based upon their characteristics, biochemical characteristics. You can have soluble as well as insoluble fiber. Soluble fibers are viscous and gel forming. Insoluble fibers are non-viscous. Soluble fibers are highly fermentable, while the insoluble ones cannot be digested. The soluble fibers have beneficial effect on gut microbiota, while the insoluble ones do not have too much of an effect on that. Do remember that when we think of the gut microbiota, these are trillions of cells in our gut, and we call them the second endocrine system because they actually influence endocrinology of the body. They speak with the brain, they speak with metabolism, with the pancreas, they speak with the bone, they speak with our mood, and they also listen to our brain, our metabolism, our pancreas, our bone. So that's why the gut microbiome is known as the second endocrine system of the body. It is also known as the second gene pool, because actually there are more cells in the microbiome than there are in the human body. Soluble fiber also increases the production of short chain fatty acids like butyric acid, which have a beneficial effect upon metabolism. Soluble fiber comes from vegetables, berries, and fruits, also from nuts, lentils, beans, and legumes, as well as from grains. Insoluble fiber comes from whole grain, bran products, fruit skins, and legumes as well. Both have different physiologic effects. Soluble fiber delays gastric emptying, improves glucose control, improves cholesterol levels, promotes weight loss, while insoluble fiber increases fecal weight and promotes bowel motility, and therefore prevents and treats constipation. It also helps in promoting weight loss. Now that we've understood the classification, the sources, and the effects of dietary fiber, we can understand the overall physiologic effects in three simple words. Number one, there are intrinsic effects, intrinsic beneficial effects of fiber. That is the pro-satiety and the pro-intestinal motility effects. Secondly, there are colonic effects. If you remember, we spoke of the gut microbiome and of butyric acid. So fiber increases fermentation. It increases the production of short chain fatty acids. And number three, we have endocrine effects through which or in which dietary fiber actually leads to increased insulin sensitivity, decreased insulin secretion, and reduction in glycemic variability. So these are the physiologic effects of fiber. But if there are effects, then is it possible that there is a chance of overdosing or underdosing ourselves with fiber? Actually, there are various guidelines. All of them are in overall concordance with each other. But from our ICMR and National Institute of Nutrition 2020, we get a guideline that our intake should be 40 grams of dietary fiber per every 2000 calories consumed. So 40 grams per 2000 calories consumed is what we should aim for in India. But different foods have different fiber contents. Some of the foods with the highest fiber content include bitter gourd at 16.6 grams per 100 gram of edible portion, soybean at 15 grams, whole grain wheat at 12.6 grams, and oats at 10.3 grams. Amongst the nuts, almonds have the highest fiber at 11.2 grams. But this information becomes very confusing for us, and we are not able to translate it into culinary medicine or culinary advice. Therefore, we promote the concept of FDN or fiber-rich diabetes nutrition. We all talk of the three macronutrients: carbohydrates, fats, and protein. And rightfully so. But to these three, we should add a fourth angle, and that angle is fiber. If we speak of fiber-rich diabetes nutrition, we will automatically be able to get a balanced diet, which will be adequate in protein and carbs and fats, but will also give us the fibers and will allow us to benefit from the physiological effects of both soluble and insoluble fibers. These benefits are well known to all of us. In diabetes, we will have better metabolic health, better glucose control, lesser insulin resistance, less triglycerides, less cholesterol, and overall, we might even be able to achieve diabetes remission, or if not that, certainly we'll be able to achieve a reduction in dose of anti-glycemic or anti-diabetic drugs. If we use too much of fiber, again we can get in trouble. Bloating, flatulence, and diarrhea, these may occur. Some people with celiac disease, for example, may have to avoid wheat. So therefore, we need to be careful when we advise a high fiber diet to our patients. If someone is not used to taking fiber at all, we should start low and go slow. Begin taking a high fiber breakfast, add salads, but go up slowly. Drink large amounts of fluid or water or other clear fluids like lemonade, and this will help avoid constipation. The way food is prepared and cooked can also change our fiber content. Unfortunately, there is no single take-home message for this. We have to understand that if you are soaking mung beans, then fiber will go down. If you boil rice, fiber content goes up. But upon boiling, the fiber content of barley, wheat, and nuts will go down. Roasting will increase the fiber content of wheat, rice, moong dal, and soybean, but will decrease fiber in groundnuts. There is one simple message, however, amongst all these complicated things that we have to remember, and that is that when you use a pressure cooker to cook food, fiber content does go down as compared to if you're cooking with microwave or in an ordinary manner. We should be aware of all these things. So now we've realized that fiber is important. We need a minimum of 40 grams of fiber per 2000 calories. We shouldn't take too much of fiber. And if we focus on home cooked medical nutrition therapy, the nutritional benefits, the health benefits are there. But we have to be aware of how this food is cooked at home. It's therefore important to work with a trained professional to create or to craft an individualized diet meal pattern for each person living with diabetes. Such a dietary advice should offer healthful food advices, direction on portion control, and also on eating patterns. And such a program will actually help ensure that fiber-rich diabetic nutrition is provided to manage type 2 diabetes. At times, formula grade or medical grade MNT, formula grade or medical grade fiber-rich diabetes nutrition can be used as a partial meal replacement or as a full meal replacement to help ensure good fiber intake and to help ensure good portion control, glucose control, and weight management. Using medical grade FDN or fiber-rich diabetic nutrition also helps maintain dietary sufficiency because you ensure that all micro and macronutrients are given in the required quantity. So this is what the decode or the expert consensus on FDN has to say. We must increase the intake of fiber. This will be done by taking more high fiber foods or fiber supplements. While both soluble and insoluble fibers are important, soluble fibers are more important from a metabolic point of view because they actually impact metabolism and they work through the gut microbiota, which is our second endocrine system. If we use fiber-rich diabetes nutrition, we will be able to improve glucose control, lipid levels, and help in weight management. So that's what we request all of us to do. Make fiber-rich diabetes nutrition an active part of MNT, an active part of type 2 diabetes management. Add fiber as the fourth angle to our three macronutrients. Thank you. Good day, friends. It's a very pleasant experience being with you, but it's even
Dr. Unnikrishnan, you can start now.
Okay, thank you. Am I audible and are my slides visible? I hope I'm audible and slides are visible. Yeah, so thank you and glad to be here again at the RSSDI. So I'm going to talk about glycemic trends in metropolitan versus non-metropolitan cities. 1 year result of the landmarks trial. And this study, many papers of the study have been presented in this conference. And this is just one study where we see the glycemic trend and compare it with metropolitan versus non-metropolitan cities, an encore presentation following. So to introduce the topic, 77 million people in India have diabetes, and India is the second largest affected country in the world. Surveys suggest that around 10 to 16% of urban and 5 to 8% of rural population have diabetes. However, in urban India, no real information on trends in the diabetes management comparing metropolitan and non-metropolitan cities are available. Hence, this subsidiary analysis from the landmark study evaluated the impact of glycemic control, treatment adaptation on vascular complications, and of course, I'll be presenting only the glycemic management trends. So let's look at the objective, which is to identify the trends in glycemic control by looking at the change in HbA1c, fasting plasma glucose, and postprandial plasma glucose at the end of 1 year in patients with type 2 diabetes in metro and non-metro cities. So the study design, this was a 3-year nationwide multi-center prospective observational study. And this mirrors the real-life diabetes management from India, registered in, of course, a CTRI. Inclusion criteria is age 25 to 60 years, type 2 diabetes for more than 2 years, on 2 anti-hyperglycemic medications. Patients visited every 6 months, and I'm presenting the 1-year data, but it's up to 3 years. And the endpoints are both the microvascular and macrovascular. And these were the metro cities: Bengaluru, Chennai, Delhi, Hyderabad, Kolkata, and Mumbai. So 382 sites from India. And we had 5,654 people at the end of the 1 year to evaluate. So the metro cities were 2378 and non-metro cities were 3858. The age was similar, 52. Duration of diabetes was similar, 8.6, and A1C was similar. If you see the A1C change in metropolitan cities on your left versus a non-metropolitan cities on your right, the blue color being the baseline and the green color being the final value, you will see that in both metropolitan and non-metropolitan cities during the follow-up, there was a reduction in A1C, 8.1 to 7.6, 8 to 7.6. And this difference was not statistically significant. The change from fasting plasma glucose also in the metro cities came down from 143 to 130, and in the non-metros from 142 to 129. This also was not statistically significant. If you look at the change in postprandial glucose control, the values came down from 205 to 183 in the metro cities versus 206 to 189 in the non-metro cities. And this difference, the p-value was a borderline 0.0508, but this wasn't statistically significant. So this is probably the first of its kind evidence from India, which reports glycemic trends between metropolitan and non-metropolitan cities. And this will aid in understanding disease management and treatment pattern across India. In this first year, patients from both metropolitan and non-metropolitan cities showed improvement in glycemic status and similar trends for change in glycemic parameters. These results will help us compare the longitudinal glycemic pattern across India, and data indicate that the area of residence has no major impact on glycemic parameters. The study was sponsored by Sanofi and there was writing assistance provided. Once again, friends, thank you for listening to me. It has been a pleasure participating in this meeting.